On behalf of CMAI, I welcome each and every one of you for this second webinar in uh, schedule. And this is how safe is looking at the non-clinical aspect of it. We will move beyond the clinical protocol to explore the often overlooked non-clinical hazards that can compromise the patient data safety. While we excel at surgical techniques and patient protocol, disasters like Army Hospital fire in 2011 that killed over 100 people. Also, the floods that caused about 18 deaths in New York Hospital in Chennai. That reminds us that non-clinical risk can be equally catastrophic. Distinguished panel will bring real-world experience from the front lines of disaster response. They have witnessed firsthand how electrical failures, floods, fires, and infrastructure breakdown can transform a sterile controlled environment into a life-threatening situation within minutes. This discussion will focus on creating a holistic safety net that encompasses not just patient identification and aseptic techniques, but also structural safety, equipment reliability, environmental controls, and all hazards preparedness. We'll explore how hospitals, particularly physician hospitals with limited resources, can build resilience against disasters that respect no boundaries between clinical and non-clinical domain. So now I'll hand over to Dr. Rajiv Nathan. He is the chairperson of doctor section of CMAI. He is also the medical superintendent of PLN Community Hospital, Shadra, to introduce the panel of speakers and the experts. Over to you, Dr. Rajiv.
Thank you, Abhijit, and it's my privilege to introduce the speakers. I have known Mr. Peniel for such a long time. Mr. Peniel Malakar has worked as a hospital administrator for more than 13 years and as humanitarian practitioner since 2006 till date. He developed and trained thousands of healthcare executives in government as well as NGO hospitals in hospital disaster management in India and Nepal. He has contributed to national as well as international hospital safety aspects at various platform levels for close to 2 decades now. He is currently practicing as consultant in health and humanitarian fields. He started Preethi with several practicing experts from India and Germany with the purpose of building resilience to health, education, and community. Currently, he is engaged in developing the HDM certification course for a university in India with support from CMC's district education program. He has also authored the part of Hospital Disaster Management course curriculum for ICMBA. We welcome Mr. Peniel Malakar. The next on the panel is Dr. Neeraj George. He is the Associate Professor, Department of Safety Officer and Quality Manager at CMC Vellore. He has also been involved as faculty on safety and quality in the Emergency Medicine Department and currently is part of HDM course with Mr. Peniel. Third is our dear Dr. Indra Napit, the orthopedic surgeon and research director from the Leprosy Mission, Nepal. He has had living experiences with fire as well as earthquake, which happened while a surgical procedure was going on. We also welcome Dr. Preethi Venkatachala. She is the Associate Professor, Department of Obstetrics and Gynecology, St. John's Medical College Hospital, Bengaluru. And we have Dr. Prabhu Joseph on the panel, the orthopedic surgeon and managing director of Duncan Hospital, Bihar. We welcome you all, sir, for this webinar to share your insights and valuable discussion that will take place now. I hand over to Mr. Peniel Malakar for further webinar programs.
Good afternoon to all. I'd like to thank you, CMA, Dr. Abhijit, and our dear friend Dr. Rajiv, who were part of the team for really rolling out hospital disaster safety programs across. One thing reminds me of when we think about disaster preparedness. from the Bible is about Noah and also about Joseph, how they have foreseen, they foresaw the situation and prepared, irrespective of people not willing to understand or not able to understand. They went ahead and planned, and we see the result being prepared. They were the best in the time of disasters. This is a series of disaster resilient hospitals, and today I'm glad that CMAI could allocate this slot for the How Safe is My OT for today, and importance on holistic safety net. Being in disaster management, I will focus more on the disaster aspect, non-clinical aspect of operating theaters or operation rooms, and focusing on the possible and visible lack of hospital safety net, not recognizing pre-hospital, pre-existing and anticipatory presence of non-clinical safety is an incomplete safety of the operation theatre, and proposed guidelines for a solution. Let me state in the beginning itself, it's not going to be solving all the problems, giving all the solutions, but basically we want you to have a thought-provoking session to say, yes, this is something that we need to really look at to make our operation theatres safer. So it's not a new thing. Operation theatres are also suffering the impact of non-clinical disasters, risks. More than 600 operating room fires occurred in United States every day. In India and many underdeveloped or developing countries, there is no record. That's why we are not able to present the whole Indian perspective. So I'll just run two small videos.
Operating room fires are rare but potentially devastating events that fortunately can be prevented by following well-established recommendations. Every member of the surgical team should be educated and trained to follow the principles of operating room fire prevention.
Another one, the fire triad in perspective of the operation theatre.
Fires require three elements: an ignition source, a fuel source, and an oxidizer. A fire can occur when all three elements merge in the right combination. In the operating room, ignition sources, fuel sources, and oxidizers abound. Most operating room fires occur during surgeries involving the head, face, neck, and upper chest. Surgery in these areas brings ignition sources close to the patient's airway, where oxidizers like oxygen or nitrous oxide may be in use. The common practice of using a source of 100% oxygen during sedation with a natural airway is the root cause of the majority of serious operating room fires. Limiting the delivered oxygen concentration or controlling the airway to keep enriched oxygen out of the surgical field are fundamental prevention strategies. For procedures in the airway, always consider limiting the concentration of oxygen to less than 30% and avoiding nitrous oxide even while using an endotracheal tube. Preventing operating room fires requires a thorough risk assessment before every anesthetic and careful management in high-risk procedures. Communication between the surgeon and anesthesia professional during the pre-procedure timeout and throughout the procedure is required to agree on the fire risk assessment, as well as confirm the use of any heat sources and the plan for managing oxidizers. In all cases, nurses and surgeons must avoid pooling of alcohol-based skin preparations and allow adequate drying time. The first question to ask during the risk assessment should be, is the patient at risk for surgical fire? Procedures involving the head, neck, and upper chest, where an ignition source is used, are considered high risk for a surgical fire due to the proximity of the airway and potential for a high concentration of oxidizer.
Well, these are the videos showing the participation of medical fraternity, especially the OT staff. Their blended experiences can prevent fire in the operation theatre. So welcome to this seminar. Would you just rank, or which one would you prioritize in terms of critical importance? Just you can make your own notes. These are probably from the perspectives of life-saving procedures, criticality in procedures, infrastructure or investment point of view, resource generation, require highly skilled staff, provides multidisciplinary care, engagement of multiple skills, reputation of a hospital, and also others. From the lens of these points, which one do you think is priority to take into considerations? For us, we think it is operation theatres, and therefore we chose to address these particular issues on the operation theatre. The problem is, we know, as we already mentioned, not recognizing pre-existing and anticipatory presence of non-clinical risks in operation theatres. What are non-clinical risks? See, in disaster management, things are so unlimited and so broad, we cannot cover everything, but these are all non-exhaustive, lists. Think about hazards: the fire, floods, earthquake, storm, structural collapse, gas leakages, etc. Most of our mission hospitals are quite old, including OT, and other structures are quite dilapidated, needs renovation or restructuring. Think about vulnerability of patients, staff, equipment, technology, occupational health, and lack of capacity, exposures to existing unidentified risks, lack of proper planning for response. There was a fire incident in Amri Hospital in 2011, 9 December, midnight, when all the eyes are closed, sleeping. The CCTVs were open, but nobody there to watch. This incident killed 100 plus patients and staff. None of them were killed by being burnt, but asphyxiation. Interestingly, the hospital was accredited by NABH, ISO, and all the certificates you can think about, they were proudly displayed. Right. And this was the landmark incident where National Disaster Management Authority woke up from slumber and developed the first hospital safety guidelines in India, and I was privileged to be part of these consultation processes. However, because of some reasons, it was not presented until 2012. But now it is presented, even still in a draft mode. These are open and available at NDMA sites. Duncan Hospital, where Dr. Prabhu's sharing also will come up. The operation theatre, the level of water, you can see, impacted the hospital. Overall hospital's revenue was impacted. So hospitals are not immune to the impact of disasters. You can see the damage statistics as well as destroyed statistics due to multiple and many different types of hazards. And fire is dominant causes of incidents here. When you see some data is not here, it is basically not available. And there are many more data that are missing. This is a huge space for study. I am adding this scope for study for damage assessment and estimation of damage of hospitals due to disasters. During the course that we are, Lord willing, it will be launched early 2026, the university certificate course. This is where our country lacks documenting, the amount of loss in addition to loss of lives due to the incidents. non-clinical incidents in hospitals. This is the recent one, 3rd July 2025, and in my city, Bangalore. Look at this situation, fire in a hospital, and it's a young doctor's presence of mind that helped preventing further destruction. Think about the outside of your operation theaters. Think about the emergency evacuation you need to do with the patients. Think about the cost of restoration. Think about the loss due to delay in restoration or restoring the entire hospital operation theater. No surgeries to be done during that time. And think about the reputation of the incidents. So holistic safety net, in brief, in a nutshell, let me present it. The clinical aspects, patient identification, pre-operation safety, aseptic and infection control, medications and transfusion safety, anesthesia and airway safety, and many other things. A lot of SOPs and protocols are there. But there are other non-clinical safety aspects which are like structural and infrastructural safety. Think about equipment and electrical safety. Think about environmental and infection safety. Infection safety refers to various infrastructure, improper biomedical waste, or even dampness in OT walls. Then all hazard safety in terms of all hazards. How many of our hospitals have identified what are the existing hazards inside and natural hazards from outside and prepare ourselves accordingly? So why is it important for hospital to undertake holistic safety measures? Often OT safety is connected to clinical safety alone to avoid medical errors, and it is basically focused on proper diagnosis and safety of patients. What about others? So non-clinical safety aspect is equally critical because there are many risks outside of patient care. Patient safety. It covers holistic safety net like fire, earthquake, floods, building collapse, landslide, storm, etc., etc. So hospitals exist to heal, but their ability to deliver depends not only on clinical safety but also on the non-clinical safety measures. So NCS in brief approach covers protection of patients, protection of staff and infrastructure, equipment, and protection of all critical resources including goodwill of a hospital. So we're talking about the entire safety of ecosystem, OT ecosystem. What is that? And briefly again, internal and external safety, environmental safety, think about infection safety, think about staff safety, patient and emergency preparedness in case of fire, in case of flood. What are the alternates? How do you rescue? What is the next step? How do you continue functioning in the operation theater despite these incidences happening? Now, non-clinical safety metrics I will share in brief because we have quite limited time and we would like to spend more time in discussions and question and answer. Structural and infrastructural safety, including the ergonomic design, the safety of the structure, the painting, the alarm system, the color-coded gas pipelines, antimicrobial coating on the walls, overall structural resilience. Think about equipment safety, scheduled maintenance of various life-saving, life-giving equipments, OT lights. Today's OT lights are lighter with LCD lamps, while in the past most of our operation theaters are heavy lights on the roof. So backup generators, critical equipments, fire safety, scheduled electrical audits. Most of the fire incidents takes place from electrical sparks. and we keep adding and adding equipments after equipments, while the cable and other load capacity may not be matching. So safe use of cautery, no open flames. You have seen the video, most of the fire happening with the unsafe use of cautery, electric cautery units, fire extinguishers, load capacity. How about emergency preparedness? Is there an evacuation plan? My interaction with Dr. Preethi from St. John's Medical College, she really gave a good sight of need for evacuation plan in case of fire and other gas leakages and others. Do we have micro mock drills conducted? Do we have risk assessments? How about the response and rescue kits, backup and safe evacuation site? Where do we transfer the patient? Are there safe operation theater close by or other place where we can take the patient off? Staff training and communication and coordination, raising alert to the control room, closed loop communication. It's not spreading the entire information across the hospital to raise panic. Just a limited loop of communication, clarity in communication, coordination and external teams with the external teams. So there's a huge coordination required by the hospital team with the operation theatre team. Think about what other risks that I have not mentioned so far. You can note it down in your own notes. So institutional risks, say employee conflict. Think about obsolete technology. Think about organizational policy. So you don't have a policy for disaster management safety of your hospital, and therefore there is no exercise undertaken for safety. And therefore operation theaters and other critical units are out of your protection, non-clinical safety protection. How about environmental? Inflation, political environment, policy and legislation. Government of India is bringing many legislation and acts to make sure hospitals go through these licensing procedures. This is in addition to the NABH and other safety laws. What about the competitors? Advanced technology, climate change. Now, proposed guide to solution, as I said, it's not going to be exhaustive. A quick guide is like, what is a risk? Risk can be measured with existing levels of hazards, existing levels of vulnerability, and the capacity that you have to mitigate those hazards and vulnerability. So a hospital will have to undertake comprehensive risk assessments by using appropriate tools. There are a lot of tools. We don't have to take a 50-bedded or 100-bedded hospitals do not have to take World Health Organization, WHO's high-profile tools. Prioritize the area require immediate attention using hazard prioritization metrics. So you identify list the risk elements and then prioritize them and connect it to operation theaters and take one after another steps to mitigate and develop and implement emergency preparedness plan. Under that plan, you can work on a suitable framework to mitigate. And then once you have things in place, conduct a mock drill. It is better to do a scheduled periodic mock drill so that you can update, change of staff, new staff, whether they were inducted with the disaster management drill, whether they knows where what is kept, what are the steps to be taken. Hence, it is important to recognize the presence of non-clinical risks in OTs, operation theaters, undertake comprehensive risk assessments and treat them on priority basis. Just undertaking risk assessments is not good enough unless you treat them on priority basis. Mitigation actions to raise level of safety and resilience. There are a lot of non-structural mitigation measures need to be taken in the hospitals that we have undertaken this disaster management and preparedness programs. We have even ensured in the OTs that there are monitors and various other things which are on the wheel, and in case of an earthquake there are chances of these equipments falling apart. So non-structural mitigation measures need to be taken as well, and that will help us to have holistic safety net and mitigating those invisible gaps. Now we will listen to various through various videos, and I was, as a disaster management person, I know that doctors are busy, especially surgeons, and this time probably most of the surgeries happens. One friend from a hospital called saying, I am in a surgery in the evening today, I won't be able to join if you have a recorded version. So therefore, including Dr. Neeraj, who is in CMC Vellore, they are going through this inspection for NABH. All of them are either traveling or in their operation theater. So we have already done a recording of their views, including from earthquake and fire experience from Nepal. I'm very glad that all the multiple and various varieties of experiences will be shared hereafter.
Greetings to all. Thank you for the introduction. I'm going to talk about some of the risks, the non-clinical hazards that are supposed to be thought about to make OTs safer. As an introduction, let me ask you a question. When you think of an operation theater, what is that comes to your mind first? In my mind, sterile techniques and surgical protocols come first. Let me give you a scenario. What happens when the lights go out mid-surgery? Not because of a clinical error, but a power failure. Here we think about the non-clinical parts or non-clinical domain in the operation theater, which is usually overlooked. Support services like biomedical engineering, housekeeping, facility management are all usually not visible to us, but their failures are not. Non-clinical risks are silent disruptors of patient safety. So let's look at some of these overlooked risks in our operating theater. So how do you classify non-clinical hazards? I have classified them into 4: infrastructural, human factors, environment factors, and technological. Infrastructural risk will include your fire, electrical failures, etc. Human factors would be fatigue, communication, all that. Environmental will be HVAC failures, and technological would be equipment failures. So are there any regulatory frameworks for standardization in OTs? Yes, there are multiple ones of them. While clinical protocols usually dominate OT discussions, it's regulatory frameworks that ensure the environment in the OT is safe, functional, and compliant. Some of the standards is what I have mentioned in the first in this slide. So ISO 14644, the clean room standards are usually the standard that governs air cleanliness in controlled environments like OTs. Usually the class 7 or 8 clean room standards are what is applicable to the OTs in this. Then we have the NFPA 99, which is a US based standard addressing electrical systems, medical gas safety, fire protection, and emergency preparedness. But even in India, some of these principles are referred or referenced in hospital design and audits. Then we have accreditation bodies like the JCI and NABH, which you must be aware of. NABH accreditation is one of the most important things. It's coming up in almost all hospitals. And there are the importance of audits and documentation. Audits are not just checklists. They are usually proactive tools that identify and mitigate your risks. Documentation of your regular audits is something that ensures traceability, accountability, and helps in continuous improvement. Remember, a well-documented OT is a safe OT, even if no surgery is happening. So when was the last time your OT's HVAC system was audited? Or when was the last time your fire alarm was tested during a procedure? Think about it. So let's go into individual components. In 2022, a fire broke out in the OT of a tertiary care hospital in Mumbai due to an electrical short circuit. The surgery was mid-procedure. The fire suppression system failed and evacuation was chaotic. Thankfully, no lives were lost, but the OT was shut down for weeks. Electrical faults and flammable materials are the sources in an OT that can lead to big fires. Recently, I had a discussion with a surgery consultant as to what all factors he thinks can spark a fire in the OT from the surgeon side. So he told me that the normal cautery system, when you overbus it, it heats up. Normal mechanism. When it heats up, if there's a flammable source nearby, it can spark and cause a fire. Similarly, the laparoscopic light source. Laparoscopic light source these days are usually blue light, which is of a lesser chance of catching fire. But earlier, the laparoscopic light was the white light, which when it concentrates on a flammable source or even paper for a long time can heat up and cause a spark. This is the same concept that we would have studied in school when you use a magnifying lens and concentrate the sunlight on a piece of paper, it can catch fire. Same concept. Fire detection and suppression systems must be up to date. Fire detection system would be the main thing that actually alerts the whole OT or the whole hospital that there is a fire that's happening in one of your closed operation theaters. Suppression systems are usually water based. You would have seen that sprinklers, when it opens, water comes down. Some of the OTs are designed in such a way that inside the OT there will be no fire sprinklers, because mainly the equipments will get damaged. So the sprinklers are placed in the corridors, or the OT corridors. As soon as there is a spark or a fire inside the OT room, staff comes to the corridor and then go to safety. The OT doors are designed in such a way that usually it withstands the fire for at least 2 to 3 hours before the fire spreads. By then the fire team would be there to help you out. So the current operation or suppression systems are being more turned into non-water based system. Inside the OT also they have a non-water based suppression system, like clean agent systems of inert gases or inert components like FM200 or Novec 1230, which does not spoil your equipments. This can be thought about. Now imagine a fire breaks out during your surgery in an OT. Who leads the evacuation? Where does the patient go? Is there a backup OT ready? Do you have these things planned? Here comes the importance of evacuation protocols and drills and a fire exit plan in place. So think about all these things when you consider an OT safety, OT related fire safety. Next is electrical safety. Imagine a patient is on the table under anesthesia and suddenly the OT light flickers and go out. The ventilator stops, the monitors go blank. What happens next? So improper grounding can lead to microshocks, especially dangerous in wet environments like our OTs. Grounding, surge protection are usually taken care of by the electrical team. There is a new concept of isolation transformers which is slowly coming up in place. This might require at least 2 drips. 2 times it has to drip, or the fault has to be triggered 2 times for the whole system to drip, the electrical system. Surge protection isn't just for computers. A voltage spike can fry life-saving equipment like your ventilator. Backup systems should be checked, your UPS, generators, etc. So when was the last time your OT's UPS was load tested, or your isolation transformer, if you have one, calibrated? Is the routine inspections happening? Is the maintenance being recorded on a audit sheet or a paper? Is it well recorded? These are things that you must consider and think about. Next would be water supply and plumbing. Imagine a cardiac surgery underway. Suddenly the sterile water supply drops. The scrub nurse is scrambling now. Instruments can't be rinsed. The procedure stalls. What caused it? A plumbing leak in the basement. You would have a backup water supply. Sterile water isn't just clean. It must be meeting its microbiological chemical purity standards. There is a lot of standards for that also. The water is being used for irrigation, rinsing instruments, sometimes even wound care in the OT. Contaminated water can produce pathogens directly into the surgical field. There is a biofilm formation also that can happen in the pipes if not frequently checked. So redundant pumps, dual water lines, and real-time pressure monitoring systems are essential. Water is usually taken granted for in the OT, but when it fails, everything else can fail. So make plumbing also part of your safety conversation. HVAC and air quality. HVAC and air quality, let's picture an OT with perfect sterility protocols, but the air contains fungal spores. The patient develops a post-op infection. What is the cause? A clogged HEPA filter. Usually laminar flow systems are used in OT, which is unidirectional low turbulence stream of clean air over the surgical site. There has to be continuous monitoring of the pressure systems, temperature, particle counts that is being done. You should have contingency plans when an HVAC failure protocol happens, like shifting to backup OTs or delaying electric procedures. And HVAC is not just about comfort and AC, it's about control. And in the OT, control means safety. Next is radiation safety. A CM is used during a procedure. The surgeon stands close, unaware that the shielding panel is misaligned. Over time, repeated exposure adds up. Months later, he is flagged for exceeding safe radiation limits. And then he is not allowed to do the same kind of surgery where radiation is happening. So training must include proper positioning, equipment handling, and emergency protocols. Signage should be placed wherever necessary, where you think that radiation exposure is going to be higher. Even non-clinical staff like cleaners, technicians, and people who are using the machine, and apart from the non-clinical staff in the OT, should also be aware of the radiation exposure. Are you aware that the occupational radiation exposure cutoff for doctors is an annual effective dose of 20 millisieverts, which is averaged over 5 consecutive years? In 1 year, you are not supposed to have more than 30 millisievert exposure. A portable chest X-ray machine has a radiation of 0.025 if you stand within the 2 meter radius or 6 feet radius of misaligned radiation. Not more than 6 feet usually. A CM will have much more than that. So this must be aware of. Only if you are aware, you can always teach or tell other people. And audits should include shielding integrity, signage visibility is present in different parts of your OT where the radiation is going to be happening, and staff compliance. Documentation should also be done on regular basis. Now we deal with chemical safety. Now comes the human factors and culture. This one and the next coming slide comes little bit overlapping. So nurse 12 hours into a shift mislabels a medication. The surgeon, distracted by a phone call, doesn't double check. The anesthetist assumes it's correct. The result, a near miss that could have been fatal. OTs are itself high pressure environments. Long hours, complex procedures, multitasking increase our cognitive load. Especially in our country where doctors and OTs are lesser in a ratio when you look at the population of the country. And apart from that, we have a lot of distractions, phones, alarms, overlap conversations can break out critical focus that is required during a surgery. Communication failures are among the top contributors to adverse events in surgery. Have you ever paused and asked, did anyone or everyone hear the instruction I said clearly? And you might have incidents that happen in the OT, minor drug errors. Things like this should be, the culture of reporting should be encouraged in your hospital setup. And if the staff, they should not be feeling scared, oh, if I tell this, they will scold me. It should be, you can make it anonymous reporting, regular debriefing procedures can be put in place, and some psychological safety is the key. Culture is not built by policies alone, but by people and leaders who model openness and accountability. So make reporting also a culture in your system. And training and simulation can continue, can form a closed communication loop. These are basic things that has been taught in an ACLS class and BLS class, also closed communication loop. So when you talk, when you actually respond to it, the other person knows that I have told an order and he knows what I have said clearly and it's followed. There's no mistake. So make it a regular way to, even while you're talking regularly in your OT, make some small drills where you can train all these things. The most important part is communication during a crisis. When there is an error that happens, everyone just wants to shout and, oh, what is this? Oh, maybe at that point of time, calm down, think, try to professionally communicate and solve it in a very professional way instead of scolding or shouting at the other person, which may not work well. Again, if I talk about this, I can go on for a long time, so I'm cutting short here. This is what I meant, the noise, acoustic hazards. So during a complex surgery, the OT is filled with beeping monitors, the HVAC hum, and overlapping conversations. Over that, the orthopedician in the OT or the surgeon in the OT is kept loud music because he wants to operate during music. Again, this causes distractions. Over that, the noise level should be monitored using decibels. You cannot have a lot of noise in the OT, not just because you get irritated or distracted. Noise is also a hazard on its own. Staff should be trained to recognize when the noise becomes a hazard. Again, monitoring and mitigation should be planned. In a busy OT, a bag of biomedical waste was mistakenly placed in the general trash. It contained sharps. Housekeeping member staff was injured. The hospital faced penalties and the staff member faced lifelong consequences because there was an HIV stain needle. Housekeeping and support staff are often most exposed but the least trained in our system. Segregation in biomedical and hazardous waste are being trained to all the doctors and all the staff. We should make it a point that the housekeeping staff, who are usually the less learned among the lot, to understand the importance and be trained in waste management. Safe disposal protocol should be in place. PPE uses like gloves, masks and aprons must be provided and enforced among the housekeeping staff. The importance. Some of them just put one glove or half a torn glove and do their work. It has to be stressed that the importance, what can happen if you develop a needle stick injury from an HIV patient or things like that should be stressed to them. Only then they will understand that such things. Lighting and visibility. During a laparoscopic procedure, the overhead light flickers. The surgeon adjusts it, but the shadowing affects visibility. A minor error occurs, but not to skill due to lighting. Lighting should support the posture and workflow of the surgical team. Overhead lights, task lights, ambient lighting must be positioned to reduce fatigue and enhance focus. Ergonomic considerations like even color temperature matters too. Like cool white light improves visibility, but warm tones reduce eye strain. So small things like this. And do we have emergency lightings in place? Like it can even be a emergency lamp, the emergency light. Is it there in your OT? Like a backup when there's a power failure. Things like this should be thought about. One of the major components of disaster management, a mass casualty surge. When there's a mass casualty surge, for example, a bus accident floods the emergency department with 30 trauma patients who might require surgery, the OTs must activate surge protocols. Do you have staff enough? Do you have enough supplies? Are you ready to coordinate among all the major stakeholders in such a situation? So here comes surge capacity planning. Infrastructure readiness, your coordination communication with the real-time communication with the ED, with the ICU and the logistics and whatnot. The communication with the hospital incident command system when a disaster like this breaks out. Staffing and workflow. You might require cross-trained staff from other departments to help support staff, to help staff in the OT. Shift rotations might have to be done to prevent fatigue, but do you have a plan for that is the main question. If you don't have a plan for that, if that is the point of time you're calling in people and asking them to do things, higher chance of errors, higher chance of miscommunication, confusions cannot be prevented. So this has to be planned and practiced earlier. Importance of drills. Safety infection can be affected when you have a lot of people. So think about this. Do you have systems in place to prevent that? Always after post-surge recovery, you should have debriefing and psychological support for the staff. Document and incident analysis should be done after each system. A surge event usually tests every system. The OTs must not survive the surge, it must perform the surge. It must perform during the surge actually. Only planning, people and protocols can make that possible. Security in the OT, one of the rarely discussed topics. But anyone can just walk inside. A person without credentials can enter an OT during a procedure. No one questions them and a piece of equipment goes missing. What is the problem? The breach wasn't clinical, it was security. So here this comes into place mostly when you have a mass casualty surge. When the lot of patients were moving in and out, you naturally is a breach in security. So this has to be planned. You should have, it can be in a way of biometric scanners or key card systems to open the OT door, main door. RFID badges. You must be having CCTV surveillance monitoring systems in place so you can see all these things. Equipment, data should be protected. Cyber security is again one of the most coming up problems in the current scenario, where you have, because you have many electronic or intelligent devices which requires this, internet, things like that. So all these things must be thought about. Next is the emergency supplies. So this will go in close terms with the mass casualty that we discussed about. Do you have when you have you should require or want emergency supplies needed for unexpected clinical deterioration in a patient, for example. It starts from there. A cardiac arrest happens. Do you have a crash cart ready there? An equipment failure. Do you have a backup equipment ready there? Environmental emergencies like fire, flood, power outage, all these things will require a lot more supplies. So if you look at categories of emergency supplies, it would be clinical, infrastructural and safety. Clinical would include crash cart, airway kits, defibrillators, emergency drugs. Infrastructure would include flashlights, backup batteries, oxygen cylinders in case your main oxygen supply cuts off or things like that. Safety would include fire extinguishers, spill kits, enough and more PPE, and these should be stored and marked separately, and the accessibility should be given to all who is involved in the patient care in OT. Color codes can be used to mark them for a surge, things like that, and staff should be trained and they should be familiar about how to or activate an emergency supply system when they require, and again drills as we expressed. The most important point in today's class would be simulation and safety drills. None of the things that I said would make sense if simulation is not done and safety drills are not followed. So this is the importance of regular drills must be understood and stressed. I am stressing it to all of you. If you don't do a regular drill, if you have a fire safety protocol in place, if you have a chemical safety protocol in place, if you have a mass casualty protocol in place, there is no point of having things in place when you don't have a regular drill. Regular drills is what makes everyone familiar to what is to be done in such a situation. It's better to have a scenario based training. So you give an example or you give a scenario like this. There's a fire right now. Announce it. So this only keeps happening in our hospital. So I know it should be done only, and we should develop some performance indicator to keep looking at improvements in the staff during the drill. It might be 100 times you practice or do a drill when the 101st time you might have to do in real life. If you didn't do that 100 times before, that 101 time when you have to do it, you will fail, and that fail would be something which you never want to forget in life. So do not think that OT is not just scalpel and sterility. For a fire to fatigue, safety in the OT is a full-time job for every system, screw and scrub cap. If it can go wrong, plan for it. If it hasn't gone wrong yet, train for it. So thank you.
Yes, excellent presentation from CMC, Dr. Neeraj. Yes, it's Dr. Indra Napit.
Thank you very much. Good afternoon. I'm Dr. Indra Napit. I was medical director when all these things happened at Anand Hospital, but now currently I'm research director. I'm more focused in research, but still doing clinical practice as well. So thank you very much for giving me this opportunity to share my experience that we faced during the fire in Operation Theatre, and also maybe some about the post-earthquake responses that we work together with EHA India. Yeah, we had two fire incidents in Operation Theatre, offside the Operation Theatre of Anand Hospital. The first one was electric spark from the circuit breaker. Anand Hospital is now like more than 60 years old hospital, and the building where we had Operation Theatre was almost like 40 years old building, and all the wirings in that building were from that time actually. So it's old building and old wiring, I would say. So somehow just day before that spark went out, one of the electrician changed the circuit breaker. Next day, somehow we don't know the exact cause, but there was fire in the circuit breaker. And the circuit breaker at that time was not the automatic one that now we have in these days in the new houses. So that was the one with that you take it out and then have a wire in it and then put in again. So that's a whole system of circuit breaker. So there was fire in that circuit breaker, and when we heard the sound of fire and also the smell, bad smell of that fire, we came out from the operation theater. Then I was in operation theater that day, so I saw that fire, the smoke. So immediately we put the main switch off, because the main switch was just on the side of that circuit breaker. So I put that off, and then we used the fire extinguisher. So somehow we had fire extinguisher that time, but the bad experience I always remember about that fire extinguisher is that it was on the high top, just below the ceiling. And so I tried, it's my experience actually. I was the one acting on that. So I tried to use that fire extinguisher, and when I was heading to the ceiling, so well, all the powder came to my face. That was very bad experience. So I had glass, so somehow the eyes were protected due to my glasses, but I felt that very bad. And frankly speaking now, so I was not trained how to use the fire extinguisher. So that was the first one, but somehow we put it off. It was just spark started, and we realized immediately, so we could put it down. So there was no major concern. But the second one was the bigger one, worse one, because the second one started from the doctor's room. Actually, this is the room where I'm now.
Oh,
So
okay.
this, because now the current previous operation theater is my office room now. So in this room, there was this is doctor's room, and there was a heater because it was winter time. So heater was on, and then all staff were in the operation room. So somehow that heater got caught fire through towel. The towel was just near hanging on the chair, and that heater got caught fire. And then somehow we felt smell. Actually, there was no alarm system also.
No.
So we just felt smell. Oh, there's something bad. And then from below, from we are the one first floor, from ground floor outside, from the account office area, people saw smoke going out from this window on my right. And they all screamed and said, "Oh, there's a fire in operation theater, fire in operation theater." So when staff came to this room, so it was full of smoke. So then they again used that fire extinguisher. They switched off the main switch just outside of this room, and then it was put off, but somehow there was damage that time. And that time, because the smoke was already out of the entrance door also, so we had concern about the staff and also the patient who was on the table. So all staff ran out of the operation theater, and they also had to bring patient with them. So all were just good escape from that main exit because the fire was in this room. So this is separate from that operation theater room. So that was actually a very bad experience. We had these two incidents of fire, and none of our staffs were trained how to put out the fire, how to use the fire extinguisher. There was no alarm system. So a lot of safety issues that we had to focus on later on. So only after this training through ESA, especially through you and your team. So now we, all of our staffs, except the new ones, are well trained how to actually starting with the safety issues that we need in the operation theater, the fire extinguisher, the alarms, safety issues with like oxygen cylinders, how to protect these cylinders. So these all things have now been in place, and now we have new operation theater. So that new operation theater has totally different with all safety issues. So that's my experience, and I'm very much thankful to UHA. So you were here for so many long months, actually, few months with training and everything. So we are very much appreciating you for your effort to make this place safe for us to work.
We were on time after the earthquake 2015. We found these incidents already happened and they were not in a position to prepare themselves. And this can be for anyone, any hospital, any operation theater. So it's always good to prepare holistically and see that we have a holistic safety net of not only hospital but also not only operation theater but also other units that we are going to slowly address in the coming series. So thankful to Dr. Indra, and actually he brought in many more doctors and nurses probably participating from Nepal. So thank you, Dr. Indra. So let's run rest of the videos and then we can collect the questions that are available.
Good evening. I'm Dr. Preethi. I'm an associate professor in the Department of OBG, St. John's Medical College Hospital, Bangalore. Ours is a tertiary care hospital. It's a broad specialty, super specialty hospital, almost 2,000 bedded. We have also a geriatric center. And basically, it's a tertiary care center. We get referrals all over, and it's a microcosm of medical world here right in Bangalore. So yes, and we do run a lot of OTs. In our department itself, we are a faculty of 18 in our department of OBG. And per day, including the emergencies, electives, we run a list of at least minimum of 8 to 10 surgeries per day, major surgeries per day. And our hospital as such, if you see, we have around 4 OTs in our first floor, around 12 to 14 OTs in the second floor, and another third floor of another 10 OTs roughly. So yes, a lot of surgeries apart from our departments also goes on day in and day out, 24/7. And most of us are tuned to, after being in this field for more than 17 years, I've been in this hospital now in the department of OBG. We are always on our toes and we are okay, be ready for PPH drill, be ready for eclampsia drill. Have you checked the surgical safety list? Have you checked the pre-op antibiotics given or not? So we are all tuned to a lot of clinical safety measures and clinical things which can go wrong, activating the MTP for the blood transfusion, massive transfusion protocols. So yes, we are all tuned to most of these clinical aspects of the OT. Yes. Operation theater, including all our sterility, all our precautions, antibiotics, all those things involved, especially in our field, OBG, where deliveries and things cannot be predicted. Most of the time, we land in emergencies. So actually, when you have brought up non-clinical aspects of the OT, it is really interesting and it got me thinking, what could be there? I never realized till I actually sat and thought that there could be a host of non-clinical problems in the OT too, which is usually smoothed out by other people, and we don't realize that these things can happen and how we should be responding to such situations. When you tell me non-clinical disaster that can happen in an OT, the first thing which comes to me is if there is a fire. Yes. If there is some short circuit, maybe in the AC unit, in the OT, or any equipment boils anywhere, because we store cylinders, backup oxygen cylinders are also there, wall mounted things are there. So if there can be a sudden explosion too at times. Though touch wood, we've been lucky enough in our setup, since it's a NABH accredited hospital, we run through safety checks. But if there is a fire and if there is a smoke, what would I do? What should we do? No, that is something which we need to be prepared for. Like we usually, what we usually do is we shut off that OT, that so that the smoke and all doesn't go into the spread the fire into the other surrounding OTs which are running parallelly. Also, there is an emergency glass which is broken. The fire extinguisher is always available handy inside the OT, and there is a fire which is we are all trained for it. We all mandatorily have to undergo training periodically. It's not just, yes, at the entry level only. All of us are faculty, whether they are PGs, postgraduates, they are interns, whether it is a staff nurse or it is an OT attender, everyone from the professor to the all the helpers, all of us at the entry level, we are subjected to a fire safety drill. And periodically, these fire safety, just like how we run a postpartum hemorrhage drill, fire safety drills are also conducted in the hospital periodically, so that we know where the fire extinguisher is, how to use it, what type of fire extinguisher is to be used in the given situation, how to wheel out the patient. See, we have to think about our own faculty safety, be it the hospital thing. We have to first and foremost think about the patient safety. And that too, in our OBG, we have to deal with both the mother as well as the baby. So if already patient is anesthetized, what do we do?
Yes.
You know, if you have already put an incision on the uterus, you may as well just deliver the baby, put a mop, just arrest the bleeding with some instruments, your Alice's or green hermitage, then start wheeling the patient out of the OT to a safer area, avoiding lifts and other things. Wheel the area. There is a fire exit plan. So we just follow, like how in aircraft you have the pointers, arrow marks going, showing, okay, this you have to move in this way, coordinated way we have to move like that. That is what is taught in our drills. We get the patient to a safety, and all the others who are in a position to walk and are fine, they make use of the staircase and go to a safer area. And from that area of safety, we plan further. There are other OTs running in different floors and safer areas in the wards where we can shift the patient and then do a procedure, whatever completed based upon the patient's need and time. Definitely, just like we have codes, like how we have code blue for a cardiac arrest or a pulmonary arrest, and there's a code blue team which runs in for the medical safety resuscitation. We also have a code orange, which we know you type 1111 once, that number over the telecom, repeat it 3 times, which floor you are in, and then you set code red. So that code red will indicate fire, and everyone, it is like a public voice system. Everyone is alerted at the same time. And different departments are there. We have an engineering department, we have a plumbing department, we have a biomedical department. So they gear up into action and come to our aid. Now, similarly, when there's a mass casualty, like maybe about a couple of years ago in our area, close to the hospital, there was a gas cylinder blast explosion. And suddenly our casualty was flooded with more than 30 people at the same time. So it was like the emergency staff, of course, were already there in place, but that was not enough to tackle that situation at that moment. So our chief of medical services immediately activated another code. There's a code white. Code white will go for a unrest and thing. There's a code orange. Code orange goes for all these mass casualties. So immediately that was activated, and we also have a faculty WhatsApp group So the CMA said, put a message. So all free hands were on the day. Everyone who was free at that time, just whether even if they were in the hostels, our postgraduates, our interns, our all the other professors, our assistant professors, just came to the EMED, did what they could in that 2 hours. And once that patient settled, that the crisis passed, the code was deactivated. So, and another thing, the beauty of our EMED is that we have an emergency OT even there, but one may not be enough in such a situation. So we always have a backup of our seniors, experienced professors and experienced doctors, so they would guide the juniors, and like a triage, everything was easily and beautifully managed. So I think it's very important to have such a system in place, because you don't know when such things can occur, whether it is a terrorist attack or a war with shelling, as has occurred recently. Yeah, we can't predict. We don't know when things can go wrong. So having one system in place, and another thing is periodic audits of these systems is very important.
Excellent.
See, there may be, we will assume, okay, there is an oxygen cylinder, take a mask and put. But if we don't connect to the patient, but if we have not checked whether it is working, whether the cylinder is full, then it will not serve the purpose. So similarly, all these drills, no, whether these code blue, code white, we even have a code pink, where the child abduction can occur in a hospital, especially in our department. So there is a thing, the sister will alert the security fellow will alert the gates, right to the security person at the gate. So everyone is alert, everyone is looking out, and somehow people will help in such a situation.
Peniel, would you like to share some insight from Dr. Preethi's sharing?
I think she did explain well, and in between I've shared about this is a 1450 bedded urban hospital, a medical college having 10 OTs for OBG itself. So it's a huge task, and their experience is that they have prepared well. One stage fails, the second stage they have alert, and these are the doctors who are engaged, doctors who are trained. So I would like to encourage doctors. It's your life, the patient's life, the infrastructure, the operation theatre being the heart of the entire hospital. It's always good to be prepared. So Dr. Abhijit, go ahead for the last video. It's a flood related issues and the huge economic loss that one of the largest EHA hospitals have faced.
I'm Dr. Prabhu Joseph. I'm an orthopedic surgeon principally, but I'm also the managing director of the Duncan Hospital. Duncan Hospital is located in Raxaul, which is in North Bihar on the Indo-Nepal border. It's a 200-bedded multi-speciality hospital, and it's almost about 95 years old. And it has been serving the people of Raxaul for these many years. Yeah. So the Duncan Hospital, we as of 2007, we still were the hospital entirely was the old buildings, the ones that were built in the 60s and the 70s, slowly. So we stand in the floodplains of two large rivers on either side, and there is another river which is north of us. So we're kind of locked in by these rivers. So whenever it rains, we have a flash flood, which usually abates within a few hours. So we used to flooding, and we are also in one of the zone 5 earthquakes, on the fault line between India and Nepal. So we are prone to earthquakes and floods. And this year in 2007, what happened was there was every once in a while when there's an excessive rain in Nepal, these rivers overflow. And in 2007, it just flowed into the hospital. And most of the old buildings over the years had slightly subsided. So water entered the operation theatre, and I think surgeries were going on at that point of time. Surgeries were in progress. So many of the surgeries had to be quickly closed up and patients shifted out as the water started coming in. And within a few hours, there was about 4 feet, 5 feet of water within the operation theater. Many of the electrical lines were submerged. Many of the sterile equipment were contaminated. So it happened very fast, very rapidly. So there was very little time for people to respond, and it was a pretty big devastation, because if we were at the surrounding villages had been washed away. There was a lot of loss to life and property. And specifically talking about the OT, it was a big impact, because at the time we had about three major OTs and a minor OT. So we were a very large obstetric center with about 6,000 deliveries. So about 30% of them were cesareans. You can imagine the number of surgeries that were going on. We had a busy surgical department also at that time. So, and an orthopedic setup. So a lot of work had been disrupted. And I would say, in a day we were doing about 6 to 8 major surgeries and many more minor surgeries. And all these had to be shut down. And we didn't have a modern building, right? Today we have a modern building where we have 3 stories. So back in the day, there was nowhere to shift the the OT. So surgeries had to be stopped. Patients had to be referred to other medical centers, which at that time were very less. They would have had to travel 60, 70 kilometers to go to Motihari. So put a lot of problems on people, put a lot of stress on us. The hospital had to be shut for about a week or two. The flood waters, of course, took about 4 to 5 days to recede. But they left behind, dirt and pollution and all sorts of debris that the water had brought in. So the OT was entirely contaminated. Electrical circuits were spoiled. The walls were gone. The flooring was gone. And so many surgeries had to be postponed. So in terms of affecting patient care, huge impact. In terms of loss of equipment, property, a huge amount, because that OT had to be cleaned, renovated, the wiring had to be changed. A lot of expensive, I don't recollect, but quite a lot of expensive equipment had been damaged, which had plugs at the base, cautery machines and things like that. So loss in terms of economic loss because of revenue that we had to lost because of the number of patients that we couldn't operate. So almost for about 2 weeks, 3 weeks, the OT was shut, and so the loss would have run into lakhs, and a huge amount of economic disadvantage to the hospital at that point of time. And we were one of the charitable hospitals, so a lot of poor people used to access us. So unfortunately, we could not operate on many of them. We had to refer our patients at that point of time. So all in all, a big disaster, big unfortunate incident. And again, in 2017, like you mentioned, we had another flood. Of course, at this point of time, we had the new building, the new IP ward. The OTs were shifted. But then, of course, it affected the various other departments like the stores and but by this time, hopefully, we had the OT shifted to a much higher level. So the OTs and the inpatients were functioning, whereas the OPDs, the offices, and the stores were very badly impacted. So flooding has hit Duncan very badly on more than 2 occasions, I should say. Yeah. So what we did, I'll just share with my experiences. We quickly went about forming a disaster mitigation team. Of course, we had help from our central office, the DMMU. They supported us. There were guidelines as to form an emergency team, a rescue team. Teams that so we trained our staff in rescue, in what needs to be done at the time of a disaster. And of course, we did an overall assessment of the hospital in terms of how we can mitigate these disasters, how to prevent them. So what lessons we learned from 7 and 17 were that you don't keep critical locations where you are prone for flooding. So we usually flood every year. It's usually lasts for a day. The flooding usually is ankle deep water, and occasionally it would enter the administrative office. So we have a habit of always placing everything about 2 feet up in the air. Nothing stays below 2 feet, nothing vital at least. So of course we shifted so after 17 we shifted the laboratories, we shifted the OTs, inpatient. Nothing critical was kept at the flood zone, other than administrative offices or waiting areas. Nothing else was in the flood prone area. So a list of areas that are flood prone. We ensure that electrical equipment was kept off, electrical circuits were not at that level. Then another risk was electrical sourcing. For example, most when a flood hits you, the first thing that you do is turn off the entire power. Then how does the OT, or how do you run another OT when you don't have the main power supply? So hospitals have to ensure an alternative power supply that is supplied to critical areas like the ICU, the nursery, the labor room, the operation theater, so that critical care services can continue. You need to focus on an alternative power supply and alternative water supply when this hits you. Fires can take place definitely during a flooding, though it seems a little odd. You can have electrical short circuits, old wires, old plug points, circuits can catch fire. And definitely you need to have a plan B. You need to know what your team will do when it floods. So we have been through mock drills, and we have been through, so we know that if an earthquake hits, how do we shift the patients? Where do we shift them? We have isolated a critical ward in the middle of the second floor, where we would probably relocate the OT. So in hospitals where you are flood prone, think of an alternative place where you would quickly shift equipment, quickly sterilize that area so that critical surgeries can continue while the rest of the hospital struggles in controlling the flood. ICUs, of course, we're talking about OTs, so I'll just focus on that. Ensure that you have an alternative plan. Your sterile equipment should not get damaged. Your autoclaves should be kept in places which are not flood prone. Electrical generators, power sources, transformers, ensure that these are not kept in flood prone locations, low lying areas. Think proactively and build. So after 17, we have all the buildings that we have built are almost 5 feet to 6 feet above the flood levels. So to ensure that even in the near future, with changes in the dynamics of the geography or region, floodwaters would not affect the future buildings. So future constructions have to be ensured that you build these much above expected floodwaters. And escape routes, assembly points. Where would you shift the OT when you have a flood? An emergency point where staff could get together. Of course, you strengthen teams. You form teams who would quickly jump into action, trying to rescue patients, vulnerable people, move equipment around, and help in firefighting, rescues, these sort of things. So that's a brief overview of how we looked at floods and earthquakes.
I think I'll just a few lines of thought. I think the doctors, the surgeons who shared from OT perspective, from the perspective of fire, flood, earthquake, there are many more. But just to brief, that our operation theaters need to be cockpit grade safety. Can you imagine you are flying from place 1 to place B and the cockpit is not ready, the pilot is not, so everything has to be well prepared. And as Dr. Prabhu said, proactive thinking, proactive action needed. And as Dr. Neeraj has nailed most of the issues related to medical doctors in operation theaters, a lot of periphery aspects that he touched extremely well. Remember, OTs are also a resource generation. OTs undertakes multidisciplinary cares, and they are life-saving activities happens in operation theater. So therefore, with these few lines, I would like to conclude from my side. Over to Dr. Avijit.
Yeah, we'll address those questions. We have part of the discussion that the presentation that we have heard from everyone.
Sure.
And also all the participants being from our mission hospitals. So a few questions that I have for all the panelists, and if you're here, you can unmute yourself and also respond. One is the first one thing is which will hold true for many of our mission hospitals is most of our hospitals are more than 50 to 70 years old, aging infrastructure. We have limited budget. So, what are the top 3 non-clinical safety risks that pose greatest threat to OT? in those kind of institutions?
See, NABH came up with quality care, and it is robust, and it seemingly was not possible for many institutions, many hospitals. What they have done is entry level, which is made easier and accessible and possible to implement with lesser budget. Disaster management, as I said, in one of the guidelines to solve these non-clinical issues is when you do a comprehensive risk analysis, risk assessment, find out 1 to 5 core issues. Like, we are not going to tell you to shift your 50-year-old hospital's operation theater from ground level to third floor, but list out things which are possible, which are reasonably budgeted, and which are critical. That way you can start creating a safe environment in your hospital.
Thank you. Another thing is, in terms of Dr. Prabhu and Dr. Indra in their presentation, they have shared about what are the things that have really helped them and what steps they have taken. So this way, at least we have some insights from that. But in terms of what we heard from Dr. Preethi's presentation about the backup system, having contingency plan if we have to move OT, and looking at the infrastructure when we don't have. So, any insights on that?
Well, being in medical college, they have humongous number of cases, and so therefore they are bound to organize themselves, make sure they have backup plans. And very often, whatever said and done, most of the hospitals we have, I showed one picture, the veranda. You see all those unconsciously blocking the space or reducing the space for evacuation. So therefore, mock drills will be very, very helpful. St. John's Medical College, CMC Vellore, they continuously conduct mock drills, micro mock drills. When your operation theater is not engaged, be sure that you do a small part of the operation theater, maybe just one day just evacuation, one day just like fire, response to fire situation. Coordination is extremely important, and hospitals where old cable wiring, electrical network, please make sure that they are updated, upgraded. Very often another mistake happens is like in operation theaters or even in ICU and ICU, etc., is that we keep adding equipments after equipment. So therefore there is a need for attention by the electrical engineer to see the load capacity and a balanced power source. Appropriate backup. Dr. Prabhu has mentioned very clearly about flood zone where everything is okay, but your generator is in the flood zone, everything will fail. And essentially, including the laboratories that they had, they were 2017 flood made a lot of destruction. Flood destroyed the laboratory equipments as well as a lot of documents. We talk about cyber security, the monitors and all those things. You can prioritize things 1 to 5, 1 to 10, and things that can be taken care of should be taken care of. We cannot expect in one go your operation theater will be safe from all the entire potential risks.
Thank you. Another thing is, what are some of the low cost, but high impact safety measures that any of our mission hospitals can implement immediately, regardless of the budget constraint, which are things that they can do, which are low cost but will have high impact.
This is very difficult because you have limited space And some of these operation theaters, when I visited some of these old hospitals, they're like 60, 70, 80 years. How many years will that hold? So it's better to have a new plan. Yes, financial constraints are there, but nowadays there are many sources. The local sources are there. Like uh, Duncan Hospital took loan from the local bank, and they have constructed a new structure. The hospital is has undertaken or considered the flood zone as well as earthquake zone, because this is following an earthquake fault line with Nepal. So this was a good investment. Instead of lamenting about we don't have resources, it is better to plan. And I understand this is a long-term investment. Infrastructural development is not easy. I mean, even renovation will not help. Some of the hospitals that I have experienced, renovation will not help.
So, I think in terms of for this panel, one question that I want to ask you and others, if they want to, the other panelists, if they want to respond. One piece of advice for a hospital administrator who feels overwhelmed by the safety requirements but is committed to protecting their patient and staff, what would it be?
Yeah, so I was a hospital administrator. What I would look at as an administrator, the first thing is what is the core point, core area where life saving is important, where even resource generation is important. So therefore, we chose based on 8 to 10 various uh, you know aspects that operation theater is something that I would invest more, and the backup system, and quite low cost investment in terms of preparing your staff. Uh, Training can prepare our mind better in terms of immediate response, emergency response. Uh, Training can help us be well prepared with less investment. So I would invest in operation theater and the periphery departments like CSSD and electrical backup system, power backup system, training, then slowly build up the other section, other departments from there. Most of my answers will be definitely focused on mission hospitals, not profit making hospitals. Please remember that our government is also bringing in a lot of legislations. Like NAPH was far from thinking in the past, it has come as a compulsory one, and hospital disaster preparedness safety guidelines is given. Slowly it will come in as an act. Fire Safety Act is there. Please study some of those cases like Amri fire incidents, which is actually which was the wake up point for the national government. Even after that also so many incidents has happened, but then that was a point where realized that we need to make sure not only displaying the certificates on the walls but also in real terms prepare your hospitals, protect your hospitals, identify the risks, and start working on one by one the critical aspects of risk and safety.
Uh, Thank you, Piniel. Yes, Dr. Indra, would you like to share something?
Yes, thank you. I want to share one incident last year when during the landslide, another one experience to share with all of you. The preparation is very important, and also the regular maintenance and checkups. Of course, mock drills also important. But what I'm focusing is that if you don't do regular maintenance and checkup of the even like the disaster boxes, disaster items, that you need for disaster management. What happened was that during the landslide in Anandaban last year, the electricity poles were all damaged. So there was no electricity, even with the generator. We couldn't supply the electricity because there was danger. So we had to stop everything, and there people started looking for torchlights. And then they went and opened the box, the disaster box, and there was torchlight, but the battery went down. So we couldn't use the torchlights. And all staffs, night duty staffs were using the mobile phones, but the mobile phones would be used only for a few hours, and then there was no electricity. So that was the biggest concern that night duty staff had during that night. And even it took, I think, 2-3 days to restore the electricity supply, even with the generator. And water supply was only after like 4-5 days. So these things needs to be maintained very well regularly on regular basis.
So one is that regular maintenance, but hospitals to some extent will have to ultimately engage or allocate somebody to work on as a safety officer. Quite many hospitals, they already have now fire safety officer, and their responsibility to make sure that emergency boxes, emergency kits are ready, backup system works on regular basis. So that will also let the staff get rid of all those aspects, and that is one of the reason that we have decided that we will have a course on hospital disaster management program where we will equip the young people, probably new generation, other than the existing staff of hospitals, to be in a position to be undertaking this responsibility. So overall aspects of hospital safety would be undertaken, and that way, the OT staff or nurses won't have to be kept busy with other things. They can be left out for contributing and giving most of the contribution and concentration on their professional part of life. Corporate hospitals, large hospitals, they have hospital safety officers in addition to fire safety officers, quality managers. So most of the hospitals also these days we have the quality managers undertaking the. So if you have a quality manager, he can be given responsibilities to work on some of those rest of those things. Thank you, Dr. Indra.
Thank you so much, opinion, insights. I think, and I think the questions were very clear, and I don't see any questions posted our participants here. I think what I'd like to do is before we leave, just want to share some key takeaways which would really help you in some practical steps. And it's start small and think big. I think the first thing you can do is conduct a small OT safety walk in this week and identify top 3 non-clinical risks. I think each one of you who are in OT will be able to do that. And also just look at the fire extinguisher. Are they working or not? Are they accessible or not? Do people know how to use it or not? It may be there, but if you don't know how to use it, it will not, it will not make any sense. It will not, serve its purpose. And also, it should be the pressure should be there. It should have been, a service. And also, like Dr. Indra said about the power, please also check your backup power system and emergency light if they're functional or not. And next is we also have to build our safety culture. When we have to every time, if you travel with me and Pinel, you will see everywhere we'll look, we'll be seeing in some sort of hazards and risk. And we're always looking at which are the way out, what all we can do, how we can protect ourselves and others. So rather than reporting, and without blaming anyone, it's better to establish a reporting system and also to speak about near miss incidents And like Dr. Prabhu said, no, they had formed a small disaster response team and also a recovery team. So if you can start with a small team, even we know that staff in mission hospitals are limited. You can start with a small team and see which are the way out, how you can evacuate everyone. And if you practice them on a regular basis, you will know it will become a muscle memory and will become easier for you to do it. Like Dr. Neeraj said, no, if you have done it for the 100th time and 101 time, it becomes easy. But if you've not done the 100th time, 101 will not happen. And these are some of the things which were shared by our, resource people. But just that for your next steps, I was thinking if you can just look at, for this month, complete a non-clinical risk assessment of your OTs. And the next 3 months, let's implement one major safety improvement, whether it is electrical, fire, or structural. And then ongoing, we spoke about drills and quarterly checking of your equipment. So Dr. Preethi also spoke about drills, and others also have spoken about drills. So have those drills, and even the opinion spoke about drills. So have those drills; it will really help you. And final thing is, the every life saved in your OT depends not just on the surgical skill, but also on the invisible safety net that keeps your theater operational when disasters strike. Patient trust you not just with their medical care, but also their safety in every dimension. The question is whether you can afford to invest in OT safety or not. It's whether you can afford not to. Well, few things which are non-negotiable, which we have to do. And start today, start small, but we need to start. We need to start at some point. So let it be, tomorrow. Let it be today that we start this culture. So that's just wanted to share in terms of some key takeaways from. So that I really want to thank and all the resource people who are there for all the protections, especially for Peniel for handling this and also interviewing all our other resource person, taking time out and scheduling interviews with them, speaking to them, and getting information from them so that it will benefit each one of you. And like we said earlier, this is a series on resilient hospitals and disaster resilient hospital. So the second one, we're looking at safe OT, and the next ones we'll look at either how to keep other areas of your institution safe, other areas of the hospital safe, like OPD, ICU, any your stores, your pharmacy. So keep looking at our mailers, keep looking at the newsletters. So you will get the information about next. And if you have registered, you will receive the emails on about uh, our next events. And with that, I think formally, I would like to close